please. Yes.
So this, I want all the fellows to have their videos switched on, and I want them to answer the questions because it's going to be an interactive session. Because otherwise it's going to be very, very boring. All right. So I had given this lecture about skeletal dysplasia as an idiot or an orthopedic surgeon's guide for diagnosis and management. So let's have a very basic talk about what an orthopedic surgeon or a pediatric orthopedic surgeon should know about skeletal dysplasias. And skeletal dysplasias, as we know, is something which is extremely complicated. If you go to a genetics textbook, then there will be just, I was just searching for it, there is just 200 types of skeletal dysplasia. And those classification that those go pages and pages and pages, and new classifications are just going on. And in those, what we will have is these sort of common terms which are thrown about: achondroplasia, pseudochondroplasia, SED, and others. And what do these mean? See, basically, genetics is at one extreme of it. Genetician, basically, they will try to find a diagnosis and some variations and some variant, and then have no treatment. On the other hand, we are as basic orthopedic surgeons, they are only interested in surgeries. What we should do is we should be in the median. We should be like a good pediatric orthopedic surgeon who will not just diagnose it at least in a basic manner, but also be humane and try to find exactly what is the minimum amount of surgery which needs to be done for that child. So can someone tell me what is skeletal dysplasia? Kartikeya, what is skeletal dysplasia?
The abnormality in the development of the human skeleton or
Correct. So basically, it is disorderly bone formation. Skeletal dysplasia is basically disorderly bone formation. So it is basically a disorder of bone formation. And we should remember that there are certain conditions which are bone formation disorders, but which are not skeletal dysplasia, which are the metabolic disorders, which are rickets, scurvy, etc. They are not skeletal dysplasias. And other causes of disorderly bone formation are infection, trauma, malnutrition, renal, hepatic causes. They are not skeletal dysplasias. So what exactly is skeletal dysplasia? Basically, it is a disorder of cartilage and bone growth, which result in abnormal shape and size of the skeleton and disproportion of long bones, spine, and skull. So the operative word here is a disproportion. So it's basically a disproportionate short stature. All right. So that is something which is very, very important. So if you look at the politically incorrect word of dwarfism, initially it was grouped under something called as dwarfism or short stature. And if you look at it, there are two types of dwarfism. One is the proportionate dwarfism and second is the disproportionate dwarfism. So Shivam, can you tell me what is proportionate and disproportionate?
Proportionate is when both the trunk and the limbs are short, sir. And disproportionate is when the limbs are short, but the trunk is of normal height.
Correct. So there may be So basically we have upper segment and lower segment, and the ratio between the upper segment and the lower segment. Usually in an adult, the upper segment is shorter than the lower segment. And if as a whole the person is short, keeping those proportions intact, it is known as proportionate dwarfism. Just to explain, there was a movie made by Shah Rukh Khan, which probably not many people saw, by the name of Zero. You remember he was like a 4 feet 11 person. So he is basically a proportionate short stature, right? And the disproportionate short stature, there was a movie when we were kids known as Appu Raja. Kamal Hassan had played this movie, this role. And in this case, you can see that the trunk of Kamal Hassan is much longer than the limb. And in these disproportionate dwarfism, these are basically the skeletal dysplasias, and they are of two types. Can someone tell me what are the main two types of disproportionate dwarfism? Who's the next one? Mohit.
Achondroplasia.
No, types. So basically, I'll go ahead. Basically, it is divided into short limb dwarfism and short trunk dwarfism, right? Short limb dwarfism is basically when the limbs are extremely short, but the trunk is a much longer trunk. And the common example, I'm sure many of you must have seen this series, Game of Thrones, right? So Tyrion Lannister was a typical short-limbed dwarf. Can someone give an example about who was a short trunk dwarf or any? So short-limbed dwarf, the typical example is an achondroplast. All right, short trunk dwarf, any condition or any person. I'm sure everyone must have seen Harry Potter and the series, right? So in Harry Potter, there was a person called Professor Flitwick. You remember this chap, right? You can see that the limb are much longer than the trunk. So which is the condition which affects the trunk much more than the limbs? Nandini, is Nandini there? नहीं है क्या? Okay. Sanika? Anyway,
No,
so this
time
is
is there. iPhone is right there. She's still
anyway.
not after 1 year or so.
Sorry, ma'am, 1 second. I'm just in casualty. I'll just get 2 minutes.
Okay.
Okay, no problem. So this is basically when the trunk is more involved. So this is typically a spondyloepiphyseal dysplasia, right? So remember, it's a short trunk dwarfism. So this chap had SED and he unfortunately passed away a few years back with complications of SED. So this is spondyloepiphyseal dysplasia, right? So remember about what you have to do. You have to check whether it is a disproportionate or a proportionate dwarfism. In disproportionate dwarfism, look at the limbs, whether it is a short limb or a short trunk dwarfism. Once you do that, then you look at the limb segments. So the limb segments are upper segment, middle segment, and lower segment. If it's the upper segment which are short, it is known as rhizomelic dwarfism. If it's a middle segment which is short, which is known as meso means middle, mesomelic dwarfism. And if it's a distal segment which is short, which is known as acromelic dwarfism. And if the entire limb is short, it is known as micromelic dwarfism, right? So rhizo, meso, and acro are the three common types. The commonest types of rhizomelic dwarfism are achondroplasia and SED. So the two common types of skeletal dysplasias are typically rhizomelic. Mesomelic is quite rare. They are mesomelic dysplasia and hypochondroplasia. And last is acromelic, where the typical thing is acrodysostosis, or once we commonly see is the streetus dysplasia, where there is acromelic shortening, right? And auto amputations, right? So this is how you devise. And look for special features. You have abnormal faces, frontal bossing, cauliflower ears, and all these weird things which we say bundle up into abnormal faces. All right. And till this time, the orthopedic surgeon's brain starts getting fried, because we don't like to think of anything much more than just X-rays. So this is the time when we get bored and we look at X-rays. And the most important way of diagnosing skeletal dysplasias is looking at the radiological features. So I'm just going to go and put forth 4 different identifying factors in order to identify orthopedically important skeletal dysplasias, right? So if you look at any X-ray of a suspected skeletal dysplasia, you should look at 4 things. Whether it is a primary epiphyseal involvement. Second, whether it is a primary metaphyseal involvement. Third, if epiphyses and metaphyses are fairly okay, but the bone density is abnormal. And last, if it is unclassifiable, you can't classify it exactly as all these, but it is unclassifiable. All right. So let's look at each of them. The most number of skeletal dysplasias are epiphyseal skeletal dysplasias. All right. So look at epiphyseal dysplasia. So this is a otherwise fairly normally grown child with primary involvement of these epiphyses. Spine is not involved, and you have this bilateral Perthes-like picture, which is synchronous. So what is the diagnosis, Shivam?
The Condylo epiphyseal, only
अरे अभी तो
epiphyseal.
अरे अभी तो स्पाइन नॉट इन्वॉल्व बोला मैंने. स्पॉन्डाइलो इज स्पाइन. So remember, it is multiple epiphyseal display. Remember, if you have bilateral synchronous Perthes-like picture, the commonest diagnosis is multiple epiphyseal dysplasias. Multiple epiphyseal dysplasia is a significantly less involved individual. Usually, height is marginally less than normal. The facies is also fairly normal. And the commonest orthopedic complaint is that they have hip abnormality. So, coxa vara, Perthes-like picture where there is extrusion, knee flexion deformities. And from the orthopedic point of view, they are very good because they have just orthopedic symptoms. They usually don't have any other systemic features, no other spine involvement. So it's a very nice surgery to do in case we actually need to do surgeries. All right. So this is multiple epiphyseal dysplasia. Next is you can see this. Karthikeya, what do you think this is? Karthik?
So there is a metaphyseal involvement.
अरे अभी तो मैं ऊपर लिखा है
Start
प्राइमरी
describing.
एपिफाइशियल
Epiphyseal.
इन्वॉल्वमेंट. अभी
Start
इधर ये देख ना,
describing, guys.
इधर
If you all are
लिख
not
रहा है रे,
sure,
ये
start
सारा इतना
describing.
एपिफाइसिस है रे बाबा.
Yes, sir.
ऑल दीज आर एपिफाइसिस ना. See if you see the bone which is looking very less dense, and we have punctate appearance. A less dense bones is typically chondral appearance. A chondral dysplasia which is punctate. So this is typically chondrodysplasia punctata. All right. So this is a very common, this is an X-ray which is very commonly seen in the neonatal period, where this is less formed, where there are multiple joint deformities, and you get X-rays like this. Spine is less involved, and typically, so chondral involvement is there where, and the abnormal feces is quite seen because there is a lot of cartilage in the skull bones at that age. So there is wide forehead, hypertelorism, depressed nasal bridge. So the abnormal facies is quite significant in chondrodysplasia punctata. All right. Next is this. You see fairly okay involvement, okay spine, and you can see there is something abnormal here. Now this is, so as we discussed, this is rhizomelic is the femur, mesomelic is the tibia. So it is primary tibial involvement, and there are three specific features in this dysplasia, which are polysyndactyly, like this, tibial involvement with tibial varus, and what is known as natal teeth. Can someone tell me what is natal teeth? Mohit? Anyone else? Sanika? What is natal teeth? Sanika है या नहीं? I think she has switched off from Wadia.
Hey. No, hey. She's very much on. But why are they on mute? I don't know. Anyway, Nandini is back, so you can ask her.
Yes, Nandini, what is natal teeth?
So is it like what we see in Ellis Van Creveld when it's
Perfect.
pointed
So
saber-shaped?
natal teeth is basically teeth which are present at birth. And these three features are typical triad of symptoms in Ellis Van Creveld syndrome. All right. So these are primarily epiphyseal disorders with mesomelic involvement. So tibia, if it is involved, it is typically Ellis Van Creveld syndrome, and additional features of natal teeth and polysyndactylies. All right. So these are the issues with Ellis Van Creveld syndrome. There's one more skeletal dysplasia of orthopedic significance. You have to do surgeries. I think we treated a few cases of, I think there was one child who was Ellis Van Creveld, right? We did tibial corrective osteotomy, right? Next, one more. another profound involvement of the epiphysis, right? Spine here is significantly involved, right? So typically it is spondyloepiphyseal dysplasia. Now spondyloepiphyseal dysplasia, remember, many a times they present with profound limb deformities. They have genu valgum, genu varum. They are very, very lax. And remember, never miss taking an X-ray of the spine, especially the cervical spine, because many a times sometimes you post them for surgery of the limbs, and intra-op you realize that he also has a atlantoaxial dislocation, and the intubation is very dangerous. So always remember about taking X-rays of the cervical spine in suspected cases of spondyloepiphyseal dysplasia. So if you have profound epiphyseal involvement with profound spinal involvement of scoliosis, craniovertebral anomalies, atlantoaxial anomalies, or in which case always remember that this can be spondyloepiphyseal dysplasia. All right. Then again, profound involvement, epiphysis as well as metaphyseal involvement. Okay. The spine is also involved, but not to the extent of SCD. You can see that there are significant deformities in the upper limbs also. And a very characteristic feature is a dwarf with a normal face. This is a normal faces. So which is this? Shivam?
So this can be any mucopolysaccharidosis,
Okay.
like
Mucopolysaccharidosis. Okay. So
dyschondrosis.
typically mucopolysaccharidosis also have abnormal faces. But this is something which is very, very interesting, that the deformities are very significant. There are no systemic features and the face is normal. So a dwarf with normal faces is pseudoachondroplasia. So remember about three things. One is the achondroplasia, typical achondroplasia. Second is pseudoachondroplasia, where the deformities are more severe than achondroplasia, but the facies is normal. And third is hypochondroplasia, where the child is almost like a short-statured person, but otherwise idiopathic short stature, but which has a few other symptoms and signs of dysplasia. So there are certain diagnostic features. I'll put it on the group about what are the diagnostic features of hypochondroplasia. So this is pseudoachondroplasia. You can see that deformities are very severe, but the facies is normal. All right. So dwarf with a normal face is pseudoachondroplasia. All right. Then last is this, again, severe epiphyseal involvement. Metaphyses are also involved. Spine is also involved. And here there are systemic features. So as Shivam said, if you have all these symptoms and signs with systemic symptoms with mental retardation in some cases, it is mucopolysaccharidosis. All right. Typically, skeletal dysplasias do not have much of systemic symptoms. If you have systemic symptoms, many a time they have this organomegaly. They come with pot-bellied appearance. Typically, this is mucopolysaccharidosis. This is so organomegaly, skeletal dysplasia, mental retardation, and developmental delay is a typical quartet of a group of symptoms, conditions which are mucopolysaccharidosis. There are a number of types of MPS. I had mugged it up when I was in MBBS or so, but I remember I forgot it the day I passed my MBBS. But the commonest is the Morquio syndrome, as we all know. But once you diagnose it at MPS, you refer it to the geneticist and the pediatrician, because there are significant systemic issues that can be life-threatening in some conditions. So the life expectancy also is very, very important to be considered. Then we come to the metaphyseal involvement, and the commonest is the achondroplasias. Here the spine is involved. Remember, in achondroplasias, there is no platyspondyly. But what is the typical feature of spine involvement in achondroplasia? Kartikeya? So the typical feature is lumbar canal stenosis in this case, large skull wall and achondroplasia. So metaphyseal involvement, the large group of disorders is achondroplasia and its variants. All right. So you can see this typical picture. You can see that the epiphysis is fairly normal, but it's the metaphysis which is involved. All right. So this has normal expectancy of life, normal intelligence, and lumbar canal stenosis is the typical feature of spine involvement in achondroplasia. All right. Then we have altered bone density disorders. So it can be either less dense, which is osteopenic, osteosclerotic, or irregular. Osteopenia, we all know about this condition, the typical features of osteopenia with fractures and deformities, which is osteogenesis imperfecta. We all know about this, which is brittle bone disease, blue sclera, and dental abnormalities. That is a typical trio of OI. Osteosclerotic, we all know about this, which is osteopetrosis. Osteopetrosis, remember, it's of two types. One is infantile and adolescent. Infantile type of osteopetrosis is extremely dangerous. It is many a times lethal at the end of the first decade itself, and the child passes away with severe infections and pancytopenia. So remember about osteopetrosis. And last is altered bone density, where it is irregular. So what is this condition? Nandini? Typical deformity with ground glass appearance.
Fibrous dysplasia.
Fibrous dysplasia, yeah. So this is typical coxavara with a Shepherd-Crook deformity. This is fibrous dysplasia, which can be monoosteotic or polyosteotic. And even in polyosteotic, it can be associated with other endocrinological abnormalities with various syndromes. Again, we deal with this quite commonly, and we need to do some surgeries in some cases. Last is miscellaneous. I'll just discuss about two cases, things of orthopedic significance. Is this? Can anyone diagnose?
Nail patella syndrome.
This is nail patella. So this is nail involvement. Patella is hypoplastic, and what are these known as?
Iliac horns.
Iliac horns. Sanika has suddenly woken up, I think. Anyway, so these are iliac horns. This is nail patella syndrome. Next is this. Can anyone see some abnormality here? Child has come with abnormal shoulders. Nandini, you are not audible.
Is it cranial disorder?
So you can't see the clavicles here. It is hypoplastic clavicles, which are cranial dysplasias. I think Madam has an article also on lengthening of clavicle in cleidocranial dysplasias.
Not cleidocranial. That was more of a clippify.
Okay. Anyway, so the question to be asked is what is the pediatric surgeon's perspective here? So basically, I'll just go ahead. So we just need to know what is the life expectancy. So what we should know about these skeletal dysplasias when they come to us for limb deformities, we should know about their life expectancy, whether it is lethal, non-lethal. We should have that basic understanding. That is one thing. Second, the orthopedic issues, we should know what are the orthopedic issues here, whether it involves a spine, whether they have come for limb shortening or the dwarfism itself, or they have come for limb deformities. And what is very important is that in case we need to operate on the child, we should know what are the difficulties which can be encountered, especially for the anesthetist, where there can be atlantoaxial instability, and you should not lead the child to have a quadriplegia on table. Right? So you should always know about these conditions. And limb lengthening is something which has been described by various authors at various places. So should we do limb lengthening in achondroplasia? So Shivam, what do you think? And if no, why? If yes, why?
In achondroplasia, sir, as such, there is no functional disability for the patient which they come across to. More or less, if they come across, if they come and tell us that some functional disability they have, we may consider. But
Okay.
as such, in achondroplasia, normally they will not have any functional disability. They can carry out their normal day-to-day activity. So it will be more of a cosmetic lengthening, after which it becomes difficult for to
So what do you
maintain
mean
the
by
disability.
cosmetic lengthening in this case? How is their cosmesis going to improve? Nandini or Sanika, anyone? See, it's not something where the person is 4 feet 11 and she wants to gain 3 inches in height, so she becomes 5 feet 2 for some whatever, for some police bharti or something of that sort, or she wants to be more yeah, the person wants to be good looking or something. It's not that way. So that cosmetic lengthening is something different. So what is the actual reason for doing limb lengthening in skeletal dysplasias or achondroplasia? So basically, what we need to do, remember, is that we are dealing with a disproportion of the limb segments, right? So the limb lengthening, if at all we need to do, is basically to decrease the disproportion of the limb segments. Whatever and how much ever you do lengthening, in how many ever steps of lengthening, femur tibia, whatever, the child is never going to be two standard deviations away from the normal height. Child is always going to remain short, but at least that disproportion is going to be much lesser if we do lengthening in this case. So basically that cosmesis is basically to decrease the disproportion of limb segments in a case of achondroplasia. Now this is very controversial because it all depends on the society. So I think Sandeep and me went to the same place at Korea where we used to do a lot of these achondroplast lengthenings. And in the Korean society, limb lengthening for achondroplasia was a very accepted means, and they used to tolerate it very well. As against that, the little people of America society, they are strongly against lengthening for achondroplasia. So it's a very societal thing. But whatever it is, we should know the reason for doing lengthening. It is not cosmetic that it is going to be like a normal height. Like parents ask us, इसके बाद normal हो जाएगा क्या? Normal क्या होगा is the proportion of the child. So he is going to be converted from an Appu Raja to 0. He is never going to be Shah Rukh Khan of the normal height. All right. So I had a few papers about it that it really improves quality of life after doing bilateral lower limb lengthening. But what is important is that I had published this very important paper in JBJ's British long time back, is that if we do lengthening of achondroplasts very early, less than 9 years of age, what has been found is that it because of the lot of pressure on the physis, the growth of the physis, which is already poor, becomes even poorer in the long term, right? So if at all we need to do lengthening of achondroplast, it has to be done after about 10 years of age. Only then will the pressure on the physis will not be so significant. All right. So thus take home points. Remember, skeletal dysplasia is about disproportionate dwarfism, divided into short limb versus short trunk, divided into segments, that is rhizo, meso, and acro. Again, classify into these 4 types. And remember about orthopedic surgeon's perspective. I'm just going to reiterate what I discussed about the radiological features. Epiphyseal, you have these conditions. The MED, which is less involved. Chondrodysplasia, which is involving the chondral tissues. EVC syndrome, which is involvement of the mesomelic part, which is tibia, along with natal teeth. A profoundly deformed child with a dwarf with a normal facies is pseudoachondroplasia. Profound involvement of the spine with severe deformities is SED, and involvement of epiphysis with severe systemic features and mental issues is MPS. So these are the epiphyseal involvements. Metaphysis is achondroplasia, which is classic dwarf. If you have altered bone density, if it is osteopenia with multiple fractures and deformities, it is OI. If it is osteosclerotic, it is osteopetrosis. And if it is irregular, it is fibrous dysplasia. And last two others of orthopedic significance, which is nail patella and cleidocranial dysostosis. Thank you. Any doubts till now?
Just a question from me. What's the difference in this American society? Why don't they want the lengthening?
Very interestingly ना, they are these वो क्या बोलते हैं, body shaming, क्या बोल that they think you should be proud of your body kind of
Body
things.
positive.
Body positive image. So the entire hey is geared towards being body positive.
Yeah, but
So
even
they don't.
access to public toilets and all
So
that,
they
it
do
does
have
matter
very good access to public toilets also. They
for
have
short limb people,
yeah.
short high
So,
stature. Then okay, then if
so
it's
they do have accessible places also. So that is not an issue. And so I was quite surprised by the amount of acceptance of limb lengthening in Korea versus absolutely no question of limb lengthening in the US. There was a vast difference. So this body positivity was a very big thing in the US for some reason.
Mm. So that's just for my, but otherwise very well taken. I think most of them fared quite okay.
Yeah. Well done.
It's nice to see a lot of interest in a subject which otherwise most orthopedic surgeons sort of shun. Sandeep, any inputs from you? And guys, you all have any doubts, you all can ask. No doubts.
So, so there's this syndrome where you have bilateral mandar and